anaerobic bacteria account for more than 40% of the cases. And tuberculosis out of a special type of infection will consider. And recurrent upper respiratory infections. Usually they may be initially viral in nature, but secondary bacterial overgrowth network resulting in sinusitis, or from there to secondary otitis. And allergy has also been postulated as a cause of chronicity of the chronic respiratory, but still it has not been proved. And usually tubal malfunction. Usually it may become blocked due to edema, and that will cause secondary death because a decreased aeration in the middle ear, resulting in proliferation of gram-negative bacteria, anaerobic bacteria especially, and leading to CSO. These are all various factors which are responsible for causation or prolongation of the infection. అమ్మా ఇది స్లైడ్ మారట్లే. So clinically and pathologically also, CSOM we divide broadly into two categories. One is so clinically and pathologically we divide this tuberous into two broad categories. One is tuberous type and second is antigrantral or tympanomastoid type. Tuberous type is again subdivided into inactive chronic otitis media or active mucosal chronic otitis media. Antigrantral type is also subdivided into inactive mucosal otitis, inactive tympanomastoid type of otitis media, or active squamosal type of otitis media. So that we consider later. Coming to the pathology, there may be some specific pathology and non-specific pathology in the case of CSOM. Specific pathology in the case of inactive chronic otitis media. So, the tumor tympanic membrane is abnormal, but the appearances depend upon the healing process upon when we examine the patient. But in all cases, there is always a loss of middle fibrous layer. So that even if it is a healed tympanic membrane, it contains only two layers. The middle fibrous layer is not present. It consists of the out epithelial layer and the middle ear mucosal layer. A healed perforation may also occur. There are only two perforations. Sometimes, many of the times, there will be a persistent central perforation. This central perforation is defined as a perforation in the far strings of the tympanic membrane with a remnant of normal tympanic membrane all around its periphery. So this central perforation, even after controlling infection by antibiotics or medical treatment, it fails to heal because of epithelialization of the edges in the perforation. The outer epithelial layer, the squamous layer, will line the edges of the perforation, resulting in histologically no defect epithelium. So there will be no stimulus for growth, and there will be a central perforation remains. And there will be changes within the residual tympanic membrane, especially the residual tympanic membrane may have tympanosclerotic plaques. So these tympanosclerosis we will discuss later is nothing but a calcification of the fibrosis which occurs in inflammation in the healing stage of any inflammation. And in the case of acute mucosal chronic otitis media, the non-secretory mucosa, which is normally non-secretory mucosa, lines the middle ear cavity. This becomes replaced by mucosecretory mucosa with number of increased goblet cells. So these will hypersecrete the mucosa. So there will be a mucoid discharge, which is typical of chronic secretory. And the mucosa is also inflamed. It becomes hyperemic, and sometimes there might be presence of mucosal polyps. And areas of granulation tissue may appear in the middle ear cavity, especially in the non-draining areas, that is around the ossicles. And these may cause active resorption and remodeling of the pore. This may result in absorption of the ossicles or result in a semicircular canal fistula, especially the lateral semicircular canal fistula. Sometimes these may erode the fallopian canal, resulting in its dehiscence and fallopian paralysis. And polyps may also get ulcerated or very rarely damage mechanisms in their. Even though if it does not occur, what happens is these will block the drainage of secretions into the external so that they may cause persistence of the infection. Coming to the non-specific pathology. Non-specific pathology means this can is potentially present in any type of CS, either in mucosal type or in squamous. So these are mainly 5 features. One is temporal sclerosis, ossicular erosion, fibrous sclerosis, mastoid sclerosis, or a cholesterol death. All these may be present in either pseudotympanic type or in antibody. Temporal sclerosis is nothing but is thought to be a long-term irreversible result of continued inflammation within the media. So this is present histologically in more than 1/4 of the years with chronic arthritis media. So it is thought to be the end result of a healing process in which collagen in the fibrous tissue hyalinizes, forming a homogeneous mass. Later, this collagen calcifies and calcification occurs, and then it forms a plate. So that is very typical clinical appearance with a chalky white plate in the remnant implant or and if it occurs around the ossicles, this may result in ossicular fixation, resulting in increase in deafness. But most commonly, this temporal sclerosis will be affecting the remnant implant. It can occur in the muscular ligaments, interosseous joints, the muscle tendons within the middle ear, or even in the submucosal space of the middle ear. The other features are ossicular erosion. So this is thought to be a non-specific result of the hyperemia. That is, it causes a hyperemic decalcification of the ossicles, which is usually associated with chronic inflammation. And this granulation tissue, especially when it occurs around the ossicular chain, and that occurs because of direction which is mediated with the mucosal folds within the middle ear. So these direct the spread of inflammation. Usually they try to restrict the spread of inflammation to the small spaces within the middle ear, like the space of the socks, contrast, all these. These are not much important for you, but they are present in the ossicles, around the ossicles and the mucosal folds. So these direct the spread of inflammation. And mucosal edema may also block the adductus adductor. It is the opening of the attic region into mastoid angle. This may get blocked and may result in inflammation in granulations. The most frequently or most commonly affected parts of the ossicles are the long process of ingress and the safest. These are the two common ossicles which are commonly eroded in the case of chronic respiratory arthritis. This is thought to be due to their delicate structure and a relatively tenuous blood cycle. Another feature is a fibrous sclerosis. So this sclerosis, fibrous sclerosis, occurs in any part with a process of healing. It occurs after any inflammation. And if this occurs excessively in the middle ear, it may lead to adhesions between the remnant implant and the middle ear structures, like the remnant ossicles or the tympanic membrane and the middle ear mucosa, resulting in adhesions of the tympanic membrane or the ossicles to the medial wall of the middle ear, restricting their mobility, thereby causing increase in deafness. And the next pathological feature is mastoid sclerosis. So in the mastoid, a secondary effect of the fibrous sclerosis is the creation of a mucosa lined by retention cysts. So this is typically called as fibrocystic lesions appear or fibrocystic degeneration occurs in the mastoid. And this itself will cause a stimulus for newborn formation. And that's indirectly result in sclerosis of the mastoid cells. So typically we call it as, clinically we call it as mastoid sclerosis. And last but not least is the cholesterol granuloma. So this cholesterol granuloma is a misnomer. It's not caused by cholesterol, but it is like a misnomer. So this is the term given to the presence of a dark brown gelatinous material with a lot of bone dysfunction. So this is primarily a viscous term. And In histologically, giant cell interactions are observed around cholesterol crystals. So these cholesterol crystals are not pathological, but they are secondary to breakdown of the blood cells in the middle. Or one theory states that this is active middle secretion. But usually, the origin of these cholesterol crystals are thought to be blood cell breakdowns. This will cause inflammation around it, and they may cause erosion of the bone structures. Coming to the clinical features, first we consider the tubotympanic type of CSOM. So this almost always follows acute suppurative effects, and usually the disease starts in the childhood, and clinically it presents as a symptomatic perforation which will not heal, and this because of epithelialization of the edges of the perforation. And typically the patient may give a history of upper respiratory infection, recurrent upper respiratory tract infection, and the infection essence where the issue into the middle ear, causing either reinfection or persistent infection. So clinically, the patient presents with a persistent ear discharge or recurrent oral discharge, even with or without treatment. There will be typical history in the case of tuberculosis, chronicity of the ear discharge and intermittent discharge. Or the discharge may also occur whenever water enters into the external ear, causing reinfection. Clinically, we divide the tubotympanic disease into three stages. One is active stage, second one is quiescent stage, and third one is inactive stage. In the active stage, we tell that the patient is in active stage whenever there is any active oral discharge. The patient comes to us with the ear discharge. Quiescent stage means an absence of oral discharge from 6 weeks to 6 months places the patient in the quiescent stage, either with treatment or not without treatment. When there is no discharge for 6 weeks to 6 months, we call the patient is in the quiescent stage. Inactive stage means there is no oral discharge, there is no continuous oral discharge for more than 6 months, places the patient in the inactive stage. This is clinically important for the management of the patient. Coming to the symptoms, the main symptoms are the told you ear discharge and deafness. In tubotympanic disease, there is typically mucoid or mucopurulent discharge of long standing, and it is non-odorous, not painful, and it is typically intermittent in nature. And it is copious in more in because there is hypertrophy of the complexes, the discharge will be mucoid and more in. And second symptom is deafness, which is usually the patient may not complain, especially in child, they have to elicit it. So this deafness usually mild in nature, but sometimes it may lead to moderate deafness. Usually, when you do a broken audiometry, it will gain less than 40 decibels. If it is more than 40 decibels, then we can suspect some vascular change involved. After coming to the examination, we have to do an X-ray examination, otoscopy, and examination to microscope to decide the type of disease and to know the pathology. So discharge, if present, should be mopped first with a dry cotton wool, or should be removed with a controlled section. So there may be presence of a central perforation, and usually this central perforation is present in active cases. In the case of active type of tubotympanic disease, always there will be central perforation, and you have to decide the location of the perforation, the type of the perforation, and note whether there is secondary or a primary. So in the presence of chronic autoimmune, the pH of the skin of the axial glands may change, and this may cause secondary infection or secondary infection by fungi because of chronic. In the presence of inactive disease, the disease becomes inactive when there is no longer any discharge, and the patient's only symptom is deafness. You have to decide the site and size of the perforation, the status of the remnant environment, whether there is any temporous process, see the middle ear through the which is visible to a large perforation. Any ossicular involvement should be assessed. So this is an indirect evidence of involvement of the ossicles clinically when you examine with a red light or with an otoscopy. There may be some foreshortening of the handle. So the most prominent part when you examine the environment is the bone structure, which will be directed posteriorly, the So if it is deviated medially and posteriorly, it is called foreshortening of handle of malleus, which is present whenever the long course of the uterus has been eroded by disease. Or the microstructural joint, if it is sometimes visible, it may also get involved, resulting in a change in the position of the handle of malleus. Look for any evidence of complications. When puberty pregnancies, these complications are relatively rare, but the signs of complications may be spontaneous misdiagnosis. Misdiagnosis is nothing but a rhythmic or continuously deviation of the eyes away from the direction of gaze, followed by a rapid movement towards the direction of gaze. And presence of complaints of any severe earache, any facial paralysis, headache, severe headache, nausea, vomiting, vertigo, drowsiness, diplopia, or a bloody ear discharge. All these are evidences of complications of CSOM. Come to the investigations. If there is any oral discharge, must be an oral fracture, calcium to throw the infective and also to the antibiotic to these are sensitive. Nodular spleen investigations are pure tone order. This is the single most important investigation for a CSOM case. When you do an audiometry, you know the type of hearing loss, the degree of hearing loss, whether there is any conductive hearing loss or etc. CSOM predominantly it causes only conductive hearing loss. But in the presence of any articular erosion or in the presence of any complications, the patient may have mixed hearing loss. Sensory neural component may also be mixed. In regular spleen investigations, there is an X-ray of the mastocytes. We have to take a lab objective that is called Schiller's view. In this view, we will be able to see the mastocytosis and any anatomical deformities within the temporal bone, like a forward-lying sinus place or a low-lying tegmental vein. This is a schematic diagram of the tympanic vein. In clinics, you are expected to draw a diagram of the tympanic vein and indicate the site for growth. So here, this is a normal tympanic membrane on the right side of tympanic membrane. The handle of malleus most prominent. This will be directed posteriorly. There will be two folds of mucosa anterior and posterior to the upper end of this handle of malleus. These are the anterior and posterior malleolar folds. The part of tympanic membrane below the malleolar folds is the pars tensa. The part above it is the pars flaccida or Schwab's membrane. This area is also called as attic region, and this is involved in the case of attic and retractable disease. In the case of pubertal disease, only the lower part of the mesotympanic is mainly involved. That is the pars tensa is involved in the case of pubertal type of disease. So through the entire the upper part, the short burst of lateral burst of malleus, and through the entire, sometimes you'll be able to see the shadow of incus. Coming to the perforation, types of perforation. Central perforations depend on the perforation in the pars tensa. There are normal tunnels, all others. So these are all central perforation. So for distributive purposes, we divide the tympanic membrane into four quadrants. We draw a vertical natural line passing through the handle of malleus. Another horizontal line at right angles to this line passing through the handle. This will divide the pars tensa into anterior quadrant, anterior quadrant, posterior quadrant, and posterior quadrant. So here, any perforation is to describe with respect to the quadrants of pars tensa. So in this case, there is a central perforation, as there is a tympanic membrane all around the perforation, and it's present in the pars tensa, we call it as central perforation. And this is in the anterior quadrant of the pars tensa. So this is a central perforation again. This is a medium-sized perforation involving the anterior quadrant and posterior quadrants of the pars tensa. Here, this is almost in all the four quadrants, anterior superior, anterior inferior, posterior in the posterior superior parts of pars tensa. So here, there is subtotal perforation. There is the annulus of the tympanic membrane. When it is involved, we call it as total perforation. Here, they are not able to see the annulus, and the bony tympanic annulus is exposed. And here, this is a perforation, the attic region. And sometimes there is another type of perforation, basically central perforation, attic perforation, and marginal perforation. And marginal perforation is said to exist whenever one margin of perforation is bounded by the bony tympanic annulus. The fibrous annulus is exposed, is absorbed, and tympanic bone is exposed. So this is more common in the posterior superior quadrant of tympanic. So this is a posterior superior marginal perforation. This is another picture. So there is different representation of how we divide the quadrants of process. Here the perforation is the anterior. Here the perforation is the anterior superior and anterior quadrant. And this is another. This is subtotal perforation. See, but they are able to see remnant of and all among the perforation. So this is a subtotal diamond perforation. You are able to see the middle structures intact and right? This is the stapes. The incus is not sealed. This is the malleus. This is the head of stapes. And this is the marginal perforation. Where one margin is bounded to the tympanic veins. And these are other types of perforation. This is the subtotal perforation. Here in this perforation, this is the large perforation. We are able to see the long process of incus and the infraosteal joint. This is incus. This is incus. This is the head of stapes. This is another type of perforation where you are able to see a small polyp projecting to the perforation of the tympanic. And this is a changes in the remnant tympanic, a healed tympanic with a tympanosclerotic phase, a chalky white patch in the vastus. This is called tympanosclerosis. And this is a traumatic perforation, just to show the difference between burst caused by disease and leaks caused by trauma. So in traumatic perforation, typically the edges will be irregular and ragged edges. The epithelium will be inverted towards the layer. In the case of disease perforation, usually the edges will be smooth. So however small or however large the perforation, the edges are smooth. The edges are even. Whereas in traumatic perforation, the edges are uneven and ragged. And this is a CT scan of the temporal bone. Usually you have to take an X-ray. X-ray is not available, and for need more detailed view, I have that CT scan. A CT scan is a high resolution HR CT scan should be taken of both the temporal bones. So typically, if you take an X-ray, that is called X-ray of mastoid, lateral oblique or shoulder. In that X-ray, we have to see the cell of the mastoid and see any anomalies of the mastoid which are common. So three anomalies are common. One is a forward lying sinus plate. This is nothing but a sinus plate plus a thin plate of bone which separates the mastoid vessels from the sigmoid sinus. And tegmented. And that is sometimes this is the sigmoid sinus plate. Sometimes this will be very thin, and this part of bone will be very thin. And this sigmoid sinus will be forward lying into the middle ear, posterior middle ear. And the second anomaly, which is common, is a low lying neural plate. Neural plate is a thin plate of bone which separates the middle ear cavity from the middle cranial fossa. This is called tegmented. Sometimes this may be low lying than the normal. And if you inadvertently do surgery and mastectomy without knowing this, you may give a post and go into the middle cranial fossa instead of clearing the disease. And the third one is which may be anomaly, is an anomalous course of the facial now. So usually that is not seen in an X-ray. So they have to take to know the facial muscles. Let's ask it a high resolution CT scan. And for comparison purposes, we should always take X-ray of both the sides or CT scan of both temples. So here this is the X-ray scan of the temporal bone showing this is the squamous part of the temporal bone, this is the extraordinary meatus, this is the mastoid part of the temporal bone, and this is the vitreous part of the temporal bone. So these are, you are able to see the middle ear cavity here. You are able to see a few ossicles, malleus, incus, and stapes, and the cochlea, the basal turn of the cochlea. And this is the lateral saptum of the lateral sensory canal. This is the sign. And here in this scan, you are able to see a thickened tympanic. And this typical ice cream cone appearance of the ossicles magazines and ethicate is the outer wall of the outer wall of the lateral wall of the outer wall or lateral wall of attitude. This is called stula. Ethicate dilemma here. See, this is the internal acoustic layers, and this is the oval bit in the states. And here you are able to see some plaque within the middle ear. So this is a tympanous process. And this is another view. This is the internal acoustic layers, the middle ear cavity, the masthead bone which is closed. In the middle ear cavity, you are able to see shadow of ossicle. And this is stapes. And this is the semicircle posterior semicircle. And this is another view where there is the tympanic movement. There is no ossicular shadow. The tympanic movement is thickened. Evidence of tympanosis. In this X-ray, I have this or not X-ray, CT scan of the temporal bone. So cellular the masthead. So this is the masthead bone where we are able to see normal or purely cellular masthead. And here we are able to see sclerotic masthead. So this sclerotic masthead may be either deep infection or eclectic antiplatelet. To know the type of masthead, let's say for comparison purpose, we must always take X-ray or the HRCT of both sides. Of course, these are both different persons, but so that cellularity happens. So normally the masthead will be cellular masthead, sclerotic masthead, or diploid masthead. Cellular masthead means there will be extensive cellular masthead. The sclerotic masthead tangentially acquired like this, or it may be via between these two. That is called partial cellular mastheads. So this degree of masthead cellular is also important. Somehow it is important in causation of the prolongation of CSOM. Coming to the treatment of tubotympanic type of chronic subcutaneous, it is divided into medical treatment and surgery. The aim of medical treatment is to control the infection and thereby eliminate the oral discharge completely, eliminate the ear discharge. So the local treatment consists of regular oral tablet and antibiotics. Medical treatment consists of regular oral tablet and antibiotics. So regular oral tablet means it can be done by two means. One is dry mopping. Second one is suction evacuation with or without debridement. Dry mopping means just cleaning the axillary outflow canal with a dry sterile cotton wool, and then just sterile remove the secretion. The idea is to keep the exodontous dry. This can also be done at institutions, that is at hospitals, by suction. Suction debridement, that is called. Suction means suction just to aspirate all the nearby secretions with this controlled suction. If you apply strong suction, it may result in ossicular debridement. Suction debridement means whenever there are any small polyps or any granulations in the middle ear, this can be easily removed by applying suction. So that is called debridement. So we can debride these small polyps. Usually they will be friable. If they are adherent, you should not remove. And only in small ones, if you don't remove it, what happens is what they do is they cause impedance for the drainage of secretions from the middle ear. They cause blockage of secretions and causes infection. So commonly this is done at institutions only, but usually try to make sufficient in most of the cases. And the second one is antibiotics. The route of administration of antibiotics may be topical or systemic or both. Topical antibiotics is a prescribed as bottle supplements or ear drops. These antiseptic ear drops, they used to be prescribed in the previous days. They are aluminum acetate, spirit, or phenol. So these will be more effective because they not only kill both the bacteria and fungi, minerals, mixed infection, but also spirit expression and fear. That brings the pH of the axonotrophic skin towards the stick side where the infections will not thrive. And second one is prescription of antibiotic drops. So these are powder supplements like boric acid drops or boric acid powder supplements or povidone powders. And these topical antibiotics, which are given as drops, are mixed with steroids or the plain antibiotic drugs can be prescribed. Whenever there is any edematous mucosa in the middle, or when there is any small granulations in the air or small polyps in the air, we add steroids to the topical antibiotics. The role of steroids is they decrease the mucosal edema. Thereby, they provide an access to the antibiotics to go to the site of. So there are various antibiotic drugs. These may be aminoglycoside drugs like gentamicin, tobramycin, gentamicin, and all these drugs. But there is a possibility of autotoxicity. And so these aminoglycoside drugs are rarely used nowadays. The beta-lactam drugs and chloramphenicol drugs. And fluoroquinolone drugs are commonly prescribed nowadays. So these are ciprofloxacin, levofloxacin, norfloxacin, norfloxacin, levofloxacin. All these drops are available as local ear preparations. This can be used in the presence of any regular organ discharge, chronic organ discharge. But the important point is none of the antibiotics will penetrate the muscles. So there lies the importance of cleaning the extractive with a dry mopping. Keep it dry, then ask the patient to instill the antibiotic. Then only they act. The second one is surgical treatment. The aim of surgical treatment in the case of leukodystrophic disease is to eradicate the disease, to promote drainage, to prevent any recurrence of infection in inactive disease, to prevent complications in the case of active disease, and also to restore function. So normally the ear infection is treated by medical means. Thereby infections controlled and discharge will be decreased or complications. Restoration of function means whenever the patient is having any conductive weakness, this restoration of hearing is usually done by surgical means. So before that surgery is completed, in the case of leukodystrophy, always we have to exclude any nidus of infection in the upper sternum. Like the patient may be having any chronic sinusitis, any deviated nasal, any hypotrophic turbinate, or any chronic tonsillitis occurring deficit, that we should be treated under medical surgical means. Then only resort to any treatment on the surgical treatment only. So in the case of leukodystrophy, usually there will be a persistent dry central profession for which the surgery advised is laryngoplasty. The laryngoplasty is nothing but a surgery done for reconstruction of the laryngoplasty. If the ossicles are removed, we can do the ossicoplasty or tympanoplasty. Tympanoplasty is nothing but a surgery done for reconstruction of the hearing mechanism and after eradication disease from middle. So eradication of disease followed by reconstruction of hearing mechanism is called tympanoplasty. Laryngoplasty is nothing but simple reconstruction. So this tympanoplasty again consists of various types: type 1, 2, 3, 4, 5 types of tympanoplasty. So type 1 tympanoplasty is eradication of disease from the ear followed by laryngoplasty. That is called type 1. Type 2 tympanoplasty is done in cases where there is partial absorption of malleus endothelius. So here the diseased malleus endothelius are removed and we place the graft over the remnant alveolus. Type 3 tympanoplasty is done in cases where there is absorption of complete absorption of malleus endothelius. So any disease part of malleus endothelius is removed and the graft is placed directly over the healthy stapes. So this is as we are fixing the newly reconstructed parameter to the stapes. This surgery is also called as laryngostabiliopexy in all the colony. And type 4 tympanoplasty is done in cases where the superstructure of the stapes is also involved by disease. So here the place is healthy and mobile. So we take away all the remnant healthy, unhealthy ossicles and we keep the grafts over the between the oval window and the round, creating a shallow medullary cavity in the hypothalamus. So this is the type of inflammation. Where the sound waves reach directly the oval window and making movements of the oval window is less exposed to the external. Type 5 temporomancy is done when the oval window is also involved with disease and it is fixed by sclerosis in the oval. It is fixed in the oval. In such condition, what we do is we remove the diseased space except the footplate of the stapes and we create a small fistula in the dome of the lateral semicircular canal and keep a graft and a bony artery between this fistula and the newly deconstructed tympanic vein, creating a small medullary cavity. So here this is called type 5 temporomancy. So here the patient indirectly hears. First, the sounds will be conducted by the movements of the graft and the cartilage or bone graft which we have removed. The sounds first will be conducted to the labrum and from there to the scrotum. So here, this is type 5 temporomancy, which may result in more complications and lesser advantage to the patient regarding hearing. So nowadays, type 6 tempoplasty is being done. So this is called type 6 tempoplasty, where we do a reverse of what we do in type 4 tempoplasty. In type 4 tempoplasty, we cover the round window and leave the oval window with the stapes exposed to the external. In type 6 tempoplasty, we cover the permanent footplate of the stapes and the round window which is covered by secondary tympan is left exposed to the external. Here the sound waves will reach the cochlea indirectly through the movements of the secondary tympan and the round, and hence this surgery is called as sonoinversion. This is the diagram with the representation of laryngoplasty. Laryngoplasty is reconstructed tympan. So first, this is a perforation. Here there are 3 layers of tympan: layer, middle carpuscle, mucosal layer. So freshening of the edges, layer edges, and the graft is spread on the tympan. So this is called overlaying implantation. If we keep the graft lateral to the tympan, if you keep the graft medial to the carpus layer, it is called as underlaying. This is the diagram information about overlaying underlaying. And nowadays, another technique is also being developed. That is interlay technique between the fibrous layer which we take. That is not important. Coming to the temporomastoid or the antecanthal type of CSOM. Here, the bone of the ant is the antrum, the mastoid is in the middle of the all may be airborne. The typical feature is the thickness of the cholesterol. There is synonyms with scleroderma, cholesterol, etc. The cholesterol is nothing but a keratinase squamous epithelial line is containing keratin and surrounded by granulation. Clinically, pathologically and clinically, we can divide it into 2 types: a congenital cholestoma or an acquired cholestoma, even though both are unrelated. Congenital colostomas are nothing but there is squamous epithelial line, squamous epithelial cysts, which may persist in anywhere in the temporal bone. Usually, during the development of temporal bone, some squamous epithelial cells remain and get entrapped within the temporal bone. Temporal bone gets ossified in 4 or 5 subcellulars, like those for the petrosmosis part, the mastoid part, squamous part, the tympanic part. So when these are merged together, some entrapment of epithelial cells results usually take a text. But persistence of this squamous epithelial cysts may cause congenital cholestoma. So if they persist in the middle area, usually they present in childhood when they don't have muscles or involved muscular. They present with effects. Sometimes if these cells are present with the effects of the petrosome, they may not present in childhood. So until adulthood only there may not be any symptoms. And in adulthood, when they enlarge and cause pressure on the 7th arm, causing a patient of palsy, or pressure on the brainstem, they present. The ideal is primary persistence of the squamous epithelial cell carcinoma. This pathology consists of histologically these are similar to any other epithelial recurrences and usually not associated with active mucosal disease unless they get a secondary infection. Acquired cholesterol is a various theories are under. Many theories have been put forward for the etiology of acquired cholesterol. These theories can be grouped into three types. One theory is any of the theories propose a negative miliary structure. Second one is invasion theory. Third one is metabolism. All the theories can be grouped into these three subcategories. The negative middle pressure, the continuous negative middle pressure due to vicious interval obstruction will cause heart arrhythmia. The fast flash tracks, the adequate tracks, and scammers tracks so much that a small squamous epithelium line pocket will be formed. And because of this narrow neck and the mucosal force, there will be retention of epithelial debris. And if it gets separately infected, it expands in the tension and forms a cholesterol. That is the theory. Various theories put forward for the explanation of negative middle pressure causing cholesterol. Second theory is many theories which cause invasion. There are two ways by which invasion of the middle pressure by the stem cell will be. One is secondary to acute rotation. An active perforation may occur and invasion of squamous epithelium into the active region may cause cholesterol. Second way by which invasion can occur. Abnormal migration of the squamous epithelium will lead to a pressure pocket and a cholesterol formation. The other theories are metaplasia. Episodes of recurrent aortic may lead to metaplasia of the mucosa of the squamous epithelium in the middle, and this expands and forms cysts which enlarge, burst through, cross flexure on the scientific region, and cause cholesterol. So this metaplasia is known to occur in any type of respiratory mucosa, not only in the middle ear, can occur in other parts of the upper respiratory. Aortic medium. Second way, where it's metaplasia, is irritation of the aortic medium of the squamous epithelium, which will lead to hypertrophy of the mucosa and gradual formation of the cholesterol. The pathological rate is nothing but a keratinized squamous epithelial lines containing keratinous tuberculosis and surrounded by granulation tissue. This granulation tissue will produce various enzymes, and that is the cause of these enzymes cause absorption of any structure which comes this way and cause complications. The naked eye evidence of the cholesterol is thin walls containing white indicated, and histologically this will contain all the layers of skin, and this is the granulation tissue with the inflammation. Sometimes this granulation tissue will enlarge because forms proteins. So once formed, the cholesterol expands and destroys any structures and the immediate structures which are at danger on the long course of interest, the fallopian canal containing the facial nerve, the lateral semicircular canal, the tegment tympani that is the roof of the area, the sinus plate which covers the sigmoid and suppresses sigmoid from the mastoidosis, etc. And these granulations produce lysozymes along with other enzymes, and these erode the ossicles. This is a typical serotonin ankle type of disease. Here, this is a past and but there is perforation, large perforation, attic roofing, and you are able to see white, there is white, which is nothing but a cholesterol. This is a diagrammatic representation. So once a cholesterol forms in the attic roofing, it extends by the ankles, opening of the middle layer into the mastoid antrum, and the mastoid antrum grows into the mastoid air cells. And there is a histological picture diagrammatic representation of the cholesterol. So there will be a matrix which is formed by a squamous epithelium, keratinized squamous epithelium around this epithelium. And this sac contains the keratinous mass, keratinous debris, which can get infected, expand on the texture, and causes erosion of the surrounding. We run the histological picture showing this matrix and the perimatrix, and this formed with a transparent squamous epithelium. And these are clinical pictures of another types of aortic disease, the attic perforation with the cholesterol white flakes, typical white flakes that you can see, Here there is erosion of the outrighting wall, the sputum, the outright wall is eroded. And here there is a mass with secondary infection with that is polyp coming out with the discharge, polyp covered by discharge in the attic region, and these are granulations in the attic region. This is the picture of the intact environment with a white, pearly white mass within the middle area. A typical examination of a congenital cholesteatoma. So this is another attic perforation. This attic perforation with the cholestoma formation and granulations are there. The central perforation, see perforation in the parts of with the presence of squamous epithelium in the middle area. So usually, colostomas are associated with attic perforation. This is the posterior perforation, along with attic, posterior attic, and the posterior part. Here there is the central perforation. So, coming to the clinical features, the discharge, the triple discharge is occurs in pneumonia adenoidal disease is scanty, less in pneumonia, even though the disease is less dangerous, the discharge is good. Here, the discharge is scanty, virulent, foul smelling, and continuous discharge. Whatever medical treatment the patient they will not have any effect on the discharge, and there may be granulations with blood stain discharge. Sometimes a crust polyp is a deafness is also a continued type of deafness, which may range from minor to moderate, and mixed deafness occurs in the sensory component. And when you examine autoscopic examination, there may be an attic retraction, attic perforation will be there, the posterior retraction of perforation will be there, or a marginal perforation will be there. So hence, depending upon this, autoscopically, this cholestoma can be classified as attic disease can be classified into four types. One is attic perforation with cholestoma. Second is marginal perforation with cholestoma. Third one is central perforation with cholestoma. And the fourth one is intact cholestoma. This occurs in the case of congenital cholestoma. Sometimes there may be retraction pocket from one side only, and depending upon the grade, there will be four types of grades. That's not important. Coming to the investigations, again we have to do as in the case of reproductive. There is an oral discharge, there is oral slab surgery. Audiological investigation means buprenorrhea, radiological investigation, the X-ray investigates to know the extent of the disease, and typically we have to take a CT. This kind of the coming to the treatment is mainly surgery. There is no role for medical treatment in the case of adenoidal disease. The principle of surgical treatment is eradication of disease and avoiding a potentially dangerous year where relatively safe. A typical surgery removing the cholestoma is a modified radical mastectomy. Mastectomy is important surgery done for eradication of disease from the mastectomy. This consists of three types. One is simple mastectomy. Second is partial mastectomy or simple mastectomy. Second one is a modified radical mastectomy. Third one is a radical mastectomy. So here we do a radical mastectomy where we extracted the mastoid from and all the mastoid cells and remove the bone separating the external canal and the mastoid. That is, remove the grids and decrease the grids, which is part of the bone, which is the lateral propagation or the propagation. Here, when we remove all the mastoid cells, what we do is we convert the medial mastoid into external canal into a large cavity, so that accumulation of and functional reconstruction is usually this cholestoma may cause erosion of muscles, resulting in some form of deafness. In such cases, what we do, if there is the muscles are intact with the patient surgery, then simple laryngoplasty and reconstruction of the flank may be after excision of the disease. But if there are ossicles are involved, a second stage ossicoplasty is always advantage, which is done later. Because the cholestoma, even if a single cell remains present, and recurrence is typical of cholestoma. So once we want to do this, we convert the mastoid cells into single vascular, allow it to dry for 3 to 6 months. And then do a second step osteoplasty. Reconstruct the ossicles for regaining the hearing. Very rarely, a medical treatment can place in the application is not necessary. One of the very small fracture pocket or a sac and where the patient last for periodical checkup and do an aspiration. So this is next I want to try this is not enough. This is the segmented money. Separate group of the earlier middle training therapy. This is the additive side and from which this side and from communicates to the middle ear. This is the part of the which is kept horizontal. And this is the sinus sigmoid sinus gland. This is the technical. These are all the master cases. And this is the master technique, the floor of the master.
उसके बाद मैं मेरा भी बता
This is the digastric ridge. And this angle is called the sinovial angle. This is the angle. The roof of
करने को साला नहीं अम्मा को
middle ear. That is the tegmental and the side sigmoid sinus gland. This one sinus. Occipitally sinus. This is the dome of lateral sinus. This is related intimately impressed for sinus. This typically posterior median to the cosine. There the short process of the impress will be. This is the diagram. So they shall not. Remove the asterectomy as like that. Yeah, all the cells are removed. The cosine is here. The impress and goes the malleus here. The long process impress here. Impress will be like this. Short process will be like this. Long process will be like this. And we are operating with the stapes. This is the facial nerve which will come lateral to the foot of the stapes. Like this is the vertical part of the facial nerve. Cannot. This is the vertical part of this is the part of the facial nerve. Not a tympanic nerve comes like this and goes to the middle ear anterior enters the canal of the ear there. There are the master vessels. Thank you. Any doubts? Come up,